Hello everyone, welcome back to Learn Neuroradiology. This is Brent Weinberg. Today we're going to do something a little bit innovative. Michael Hoch has put together a choose-your-own-adventure approach to spine lesions. To follow along here, you're going to have to choose the appropriate follow-up video from the comments below. So you're going to be given a choice about whether a lesion is aggressive or non-aggressive. So you can find those in the comments below. So now enjoy the video. He's about to begin.
Okay, welcome to another installment of Neuroradiology.com. I'm Mike Hoch, and today we're going to have some fun and channel our inner MSK radiologist on this talk entitled Choose Your Own Adventure, Approach to Osseous Spine Lesions. Kind of a homage to those books from my childhood where you could choose the chapter you were going to read for the characters, and Netflix has recently done something similar with a few episodes. So let's get started. Introduction. Spine osseous lesions are a common dilemma in neuroradiology practice. They often have nonspecific and overlapping imaging findings. Biopsy or resection is often needed for a definitive diagnosis, and CT and MRI imaging help form a differential diagnosis to guide our treatment and management of these patients. One of the goals of this talk is not to arrive at a perfect diagnosis every time, but to narrow our focus to give the clinicians a better idea of how to manage these patients. So learning objectives, we'll go over the imaging features of osseous spine lesions. We'll have a systematic approach to spine lesions, and we'll go over the approach in 5 interactive cases. So here's the most important slide of the talk. On the left, you have the aggressive lesions decision tree, and on the right, you have the non-aggressive lesion decision tree. The first decision is the most important. You're going to try and decide whether or not the lesion has aggressive features such as cortex destruction or an extraosseous soft tissue component, because then that tells you which of the decision trees to use. And this was presented in abstract form by one of our former fellows, Tom Toffoli, back in 2017 at the spine meeting. So aggressive versus non-aggressive, this is a first important distinction, determining if an osseous lesion is aggressive or non-aggressive, and these aggressive lesions have a different differential diagnosis, and they require more definitive management, such as surgical biopsy from an interventionalist or resection from one of the surgeons. So aggressive features that we're looking for: this first lesion, metastasis on the left with cortex destruction on CT. In the middle, a poorly defined margin, again another metastasis. And here's an aggressive infection with a extraosseous soft tissue component having paraspinal and epidural phlegmon. Other factors to consider, and we'll go through each one of these individually: location, age of the patient, time course, matrix formation, and the MRI appearance, assessing if there's enhancement, type of enhancement, cystic lesion, or if they have a soft tissue component. So lesions by location: the vertebra is split into half, anterior and posterior. The anterior component is made up of the vertebral body and the anterior third of the pedicles. The posterior component is the posterior 2/3 of the pedicles, the facets, and the posterior elements. And if you have a lesion centered predominantly in the anterior half, you want to think about things like hemangioma, chordoma, and LCH. If it's in the posterior half of the vertebra, you can think about osteosarcoma, chondrosarcoma, osteoblastoma, and our ABC, UBC bone cysts. And if you have lesions that can go anywhere in either the anterior or the posterior component of the vertebra, such as Mets, myeloma, and lymphoma. Patient age: younger patients, you want to think about different types of lesions such as giant cell tumor, osteoblastoma, LCH, and leukemia. Everybody should always rattle off in an older patient when they see a bone lesion, Mets, myeloma, and lymphoma in the differential. Time course: if it's an acute rapid onset, you want to think about an infection or a high-grade malignancy. If it's subacute or indolent onset, you want to think about atypical infections such as tuberculosis and fungus, or a lower-grade neoplasm. Chronic or stable lesions on follow-up imaging, you want to think about things like bone island, bone infarction, and hemangiomas and fibrous dysplasias. Matrix type: so the first type is osteoid, and that's a cloud-like, fluffy, and ill-defined matrix. You can see that with osteoid and osteomas, osteoblastomas, and osteosarcomas. chondroid type of matrix appears as focal stippled ring and arcs. Here's a case of a chondrosarcoma with an extra osseous component having that chondroid ring and arc matrix. For the purposes of this talk, solid lesions are going to be T2 intermediate in signal, so darker than the surrounding CSF in the spinal column. And on post-contrast imaging of this case, this is a lymphoma, there's going to have solid internal enhancement. Compare that with cystic lesions where the T2 characteristic is bright, fluid bright, similar to CSF, and there's no post-contrast enhancement on T1 post images, and this is a case of an epidermoid cyst. So solid versus cystic, for the purposes of this talk, solid is going to have intermediate signal on T2 weighted images, internal enhancement, and sclerosis on CT. Cystic lesions will have bright T2 signal like CSF, no enhancement, and they can be lytic on CT like this aneurysmal bone cyst of the iliac bone. Okay, so our approach before we go into the 5 cases is determine first and foremost if the lesion is aggressive or non-aggressive, and that'll be the most important lesion because that'll tell us which flow chart to use. Aggressive lesions are going to have cortex destruction, ill-defined margins, and extra osseous soft tissue components. If you don't see any of those 3, you're going to want to lean towards deciding to use the non-aggressive flowchart. As we get further in the flowcharts, we can use additional patient and imaging characteristics to narrow our differentials. Don't jump to conclusions, just move along using the flowchart as your guide. And while definitive diagnosis may not be possible, try to guide management and provide a useful differential.
Thanks, Mike. Now that we've seen that great introduction, you're going to want to proceed to the first case video. You'll find the links to the individual case videos in the comments below.